a.m. This is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Amazing. Good morning, good morning, good morning, everyone. Welcome,
Morning.
warm welcome to this morning's Khan Health Hour. Just apologies for the slight delay in starting. We were just trying to sort out some technical things, but thank you so much for your patience, and thank you so much for joining in wherever you're joining from, whether YouTube or LinkedIn or Facebook or Zoom. We are really, really happy to have you here. Please feel free to drop in the chat where you're kind of watching from, so that we know. I know we usually get people watching from all over the country and sometimes other countries as well, so all over the world. So thank you so much again and again for joining and for your patience. And also please feel free to share the link before we start with friends, families, other people in your community, so they can join us as well. So, the more people that we reach, the more lives that we can impact. So yeah, please feel free to join, to share the link. So today's session, as with all the other health hours, is a really important one. So we're going to be focusing on blood cancers, which is an area that affects many within our community, the African, Caribbean, but also the Pakistani community. So today's health hour is also special in that we will be having members of the Pakistani community and having a Pakistani doctor speaking as well. So that's really, really important. It's also a special pilot kind of partnership collaboration with Blood Cancers UK. So again, they're joining us for the first time. So a lot of new things happening today. So yeah, just want to welcome everyone, really. So as I mentioned, because today is a pilot, we're going to be trialing a few additional features today. So there should be or might be a QR code during the session or after the session, as well as a Zoom poll and survey link. So please do take a moment to engage, because your feedback will kind of shape, future sessions and things like that. So please do engage. I'm gonna stop talking in a little while, because obviously we're here to hear from our very astute doctors. So this morning, I'm really honoured to be joined by two speakers. So we've got Dr. Anjum Khan, who's a consultant haematologist at St. James's Hospital in Leeds. And he has an interest in improving outcomes for people with blood cancer, which is incredible. And then we've got Dr. Nomathamsanqa, who is a haematology specialist trainee in London, and she is an NHS AI clinical fellow. So really interesting talks from them. Looking forward to those. And then we also will have two people with lived experience of blood cancer. So we're getting a lot today. And then later on, I'll kind of mention about a peer support group, which is for anyone living with blood cancer, which is again a collaboration with Blood Cancer UK and CAR. So I'll talk a little bit about that later on. As I don't want this introduction to be any longer. So with that, thank you again for being here, and for also adding in the chat where you're joining from. That's really helpful. Yeah, let's begin today's session, and I will now hand over to our first speaker, Dr. Noma.
Hello, hi. Thank you everyone for giving me a chance to talk about something that I'm really passionate about. I will just talk about blood cancers today. I'll give a general overview because there are a lot of blood cancers in existence, and you kind of need a specialist session to dive into the depths of each condition. So we will start with just a general overview today, and then later we will go into more detail. Someone else is kindly sharing slides for me. So can we move on to the next slide? So this is just kind of a quick breakdown of what we'll talk about. So just a quick chat about blood and the different components of it. So what makes up blood? And then I'll talk through the different types of blood cancers, the treatments that are available, and just some myths and misconceptions that we come across in our practice when people first get diagnosed with this condition. So now, next slide. So, what is the story of blood? So, blood is really made in the long bones. This is information that I think everyone should be aware of when we're talking about blood cancers. So, blood is made in the long bones. If you can think about a part of the long bones called the bone marrow as a machine factory, and that machine makes red cells, which are responsible for taking oxygen around your body. And it also makes white cells, which are responsible for helping you to fight off infections. And also these little, I'm going to call them little platelet break-offs called platelets. And they are responsible for helping your blood clot when you injure yourself. So these different types of white cells, and if you look a little closer in that one, it goes through lymphocytes, eosinophils, macrophages, and neutrophils. These are terms that you become quite familiar with quite quickly when you get diagnosed with one of these conditions. And next slide, please. So blood cancers really are changes that happen within the bone marrow, which is that part of the long bones that I introduced earlier. And what happens is that you have this genetic change that happens. This change results in one type of cell growing and taking up a lot more space, and it becomes an uncontrollable growth, which is what makes it a blood cancer. So this can either happen in the bone marrow, or it can happen in the lymphatic system, which is a part of your immune system. Next slide, please. So generally, there are three different groups of blood cancers, leukemia, lymphomas, and myelomas. But there are many, many more, and some which kind of fall in between the two different, in between the different types of categories. And if you come across hematologists, there's some people that spend their whole lives treating just one category of this. This is how many different types of blood cancers they are. So we will just talk through each one and just give a general overview. Next slide, please. So if we start off with leukemias, so these tend to be cancers of the where they start off in the bone marrow. So what happens is you do have that change in one of the cells, and it causes an imbalance of production. So normally you have your body decides how many red cells you need and how many platelets you need and how many white cells. And what tends to happen is that you get a change in one of the white cells and it takes up all the space in the machine. So you get an increase in these white cells that don't work very well. So they're not doing their primary job, which is to prevent infection and fight off infections. They actually are just increasing in number and they start causing problems within the body. So typically we talk about AML, CML, ALL, CLL. So these are a lot of acronyms that are involved in hematology. Um, And if you ever get diagnosed with one of these, you do become quite familiar with it. What we tend to do is we tend to give you information and direct you to safe sources so that you can know a little bit more about the condition. Typically, what happens is you are presenting with tiredness, you've got bruising because the platelets are low, and then you're at increased risk of infections. So people tend to get recurrent infections because of they don't have much of an immune system anymore. Next slide, please. So lymphomas. So these affect part of your body called the lymphatic system, and the lymphatic system kind of spreads throughout your body. And I've put a little diagram there so that you can see that it pretty much there's lymph nodes everywhere in your body. And what typically happens is that you get swelling of one of these nodes. Uh, and then you kind of start having fevers, you experience quite a lot of weight loss. So when you are referred to us, typically by the GPs, we ask about drenching night sweats. This is where you're sweating quite a lot of night, and the sweat is such that your pillow and your bedding and your pajamas are all getting really, really wet. That's something that we will ask about. There are also different types of lymphomas. And so when you are diagnosed with one of these, we will explain some of them are more aggressive than other types, and we tailor treatment accordingly. Next slide, please. And then these myelomas. So these are cancers that affect a certain type of cell called plasma cells. And because of the way that these cancers work, they affect your bone marrow. So they will reduce the number of cells. So they will reduce your red cells. They will reduce your other white cells that fight off infection. And they will also reduce your platelets. So your blood counts are going to be low. But they also can sometimes produce extra proteins, which can affect your kidneys, it can affect your heart. They are notorious and they cause a lot of problems within your bones, and they kind of cause your bones to be thin because they go up and take up different places of your bones. So people have a lot of bony pain. Um, but quite often, if you present with a certain group of symptoms, a lot of doctors do have these cancers in mind. So they will be testing for these. And if you're diagnosed with one of these three cancers or three subgroups of cancers, you will be referred to a specialist hematology team, and we will see you and we'll manage your treatment. Next slide, please. So, when we suspect that you've got one of these cancers, these tests that we have to do in order for us to confirm that this is what you have. So, we start off with simple blood tests and we make slides of your blood and we look at your blood under the microscopes because we often get clues to which kind of cancer you have just from what we can see from the blood test. Then we take the blood and we run it through several different specialized hematology tests. So we start off with something called immunophenotyping, where we take the cells and we look at what's inside the cells, and it kind of runs through these specialized machines. Then also we do genetic tests, and this is to try and find what is the exact change that's happened. And then sometimes we do a bone marrow biopsy where we try and get a sample of, remember that factory that we talked about, so we could look in the factory to see what the change is and what's happened. And we also do some scans. We typically do different types of scans. We do CT scans and we do PET scans. We also do MRI scans. That's so we do all these tests to try and see exactly what kind of cancer do you have. We also risk stratify the cancers so that we can pick the best treatment to target and treat it well. Some of our cancers are curable, and we do really well with the ones that are curable. And some of them require treatment, so they become a chronic type condition. So when you're diagnosed with one of these blood cancers, we will have a chat with you and we'll talk to you about what kind of cancer it is and whether it is an acute one, so a more aggressive one, or it's a slow growing one. There are times where actually we don't give any treatments and we sort of sit and watch. There are times when we give supportive treatments. So these would be we give you some blood or we can give you some platelets. So when people go and donate blood, some of that blood is used to help people with cancers and we give them top ups every ever so often. And sometimes that's enough for some people for a really long time. We also give some medicines that can stimulate that factory to make more of red cells if that's what we need, or more platelets. So we are very good at tailoring the treatments to exactly to the kind of cancer that you have. And we do quite a lot of monitoring. Sorry, next slide. So this just talks about the different types of treatments that they are. So the blood transfusions and the platelet transfusions and also chemotherapy. We're very lucky in hematology because we've got really targeted treatments. These are treatments that can go and target the exact change that's happened in your bone marrow that's caused the cancer. And sometimes these treatments are amazing and they cure you of that disease that you would have got. And sometimes they're amazing because they cause that disease to go away for a long time and for you to live a normal life as much as possible, which is what we want. Occasionally, there's radiotherapy that we give, and I know some of these treatments don't have the best reputation, but actually, what I just want to say is that everyone responds differently to the treatments that we give. And so we monitor you really closely. A lot of hematology treatment centers will have day units where we will see patients. We will have 24-hour hotlines where you can call at any point. I mean, literally at any point. It could be Sunday morning at 3 a.m. in the morning. You could be having pain. You could be having a fever. We want to know everything so that we can help you really quickly. Because infections are one of the things that we see. As I said earlier, your immune system is not working very well. So we do see patients that get infections, but when you have an infection, we want to treat you quite quickly. Um, and if we can go on to the next section, please. So quite often when people are first given this diagnosis, some people, everyone would like an explanation as to why they've gotten these blood cancers. And honestly, it is sometimes quite often just bad luck. It is a change that's happened in your bone. You haven't done anything to it. Some people think they have committed a sin or someone has committed a sin in their family that's caused it. It really isn't the case. It's unlikely, and no one has cursed you into this. It is honestly just bad luck. Quite often, these cancers do not run within the family. There are very few exceptions for this. And quite often, we have an idea of families, and once we pick someone up, we manage the family, the whole family accordingly. So it is unlikely that this is something that would also happen to your children. It is often just isolated to that one person. And the chemotherapies are honestly not always bad. Um, some people go through treatment and they don't have any side effects. Some people do go through treatment and they have some side effects. It is really difficult for us to say how it is going to be for you when you have these treatments. And sometimes, occasionally, and this is where people are kind of cut off, is they feel just a little bit unwell when we call and we say, actually, you have a blood cancer and you have to come into hospital quite quickly. And initially, when we make these diagnoses, we move quite quickly and quite fast, and people feel a bit of whiplash because we come in, we say, you've got a blood cancer, we start treatment straight away. We often don't wait, and then we do other tests following that, and it can be quite a lot to take in, but we have really good support services to help you through. And our treatments don't necessarily make you infertile. There's loads of people that have had blood cancers and then have gone on to have these treatments and then gone on to have children after. So if I can go on to the next slide, please. So just in terms of support, we find that it's really helpful to tell your family members and just get as much support as possible and your friends, because these people rally up and do a lot of things like running around, do all the things that you're not able to do for yourself. But also, we have some amazing charities that realize that sometimes if you get diagnosed with one of these more aggressive cancers, your life stops as you know it, and you need help with your finances, you need help with where you live. Sometimes you need help with extra childcare. And we're really lucky because in hematology, we have specialist clinical nurses, and honestly, they are angels. They are people who are specialist hematology nurses. They specialize in helping people with blood cancers. They help you through your treatment. They often are way more available than us doctors, and they will talk you through the different types of treatment. They're available to answer questions. They often know which resources are needed. And also, we have loads of community support groups. So, depending on your different types of blood cancers. So we'll have lymphoma support group, we have leukemia support groups, and myeloma support groups. We have really good places where we can refer you for treatment. And each time before you start a treatment, we will talk you through all the different side effects and what to look out for. We always want everybody to tell us anything that they're experiencing at any point, no matter how insignificant. Um, there are times where we might refer you to clinical trials, and I'll let Dr. Anjum talk about clinical trials. These sometimes people are, I guess, a little bit intimidated by or a little bit afraid of. But I'll let Dr. Anjum talk to you about that. These are often quite rigorously monitored and normally fairly safe. Next slide, please. Yeah, so that's it. So I am going to stop there and hand over to Dr. Anjum.
Thank you, Noma, for that tour de force. And, I hope everyone can see my screen.
Yes, yeah, we can. Thank you so much. Thank you so
Fantastic.
much, Dr. Noma.
Yeah, that was an excellent run through, and thank you so much, Noma, for introducing what is a big subject. And there's so much to say about cancer as a whole and blood cancer, because as Noma has mentioned, there's so many different types. Getting access to the right information can be difficult, sometimes confusing. Unfortunately, doctors tend to use quite a lot of jargon, and so making your way through all that different signposting can be quite tricky. And as Noma says, the people who are incredibly helpful often are the team who you're diagnosed with, and they go through that journey with you. And often the first point of call is your clinical specialist nurse, and everyone who's diagnosed with cancer in the UK should have access to a specialist nurse. And if you're not given their contact details, please ask your team, because that's an important part of your care. And the idea is to be accessible and to understand what your different treatment options are. And I'm just going to talk a little bit about clinical trials, because I think there's quite a few misconceptions. And we all, when we hear the word trial, think, oh, I don't want to be a guinea pig. I don't want to be a hamster on a wheel. Why are they talking about this? I just want my treatment. I just want to get better. But actually, getting better is a multi-stage process. And the best way often to get better is to get access to the best treatment. So I'm going to talk a little bit more about why that is so bound up with clinical trials, and particularly in blood cancers. Well, if you like, there's three important key reasons as to why, when often people are diagnosed, you'll hear doctors talk about clinical trials. The first reason, most obvious, but perhaps it just needs a bit of unpacking, is that talking about clinical trials actually helps us improve care. And that doesn't mean improve care for someone in the future, in 10 years' time, because you're doing something to help the community, but not necessarily yourself. That may be part of it, but actually it's talking about improving care for you right now. Now, what's really important is you need to understand what your options are, and talking to your doctor and your nurse specialist and other people around, and also getting advice from other supportive um, areas such as blood cancer charities who are so engaged and so motivated to help people understand what their options are. But unfortunately, cancer is a moving target, and there are new treatments coming along all the time, but also the cancer can evolve and change. And so what we really want is as many options on the table as possible. And that's where clinical trials come in, because actually sometimes the treatment in trials that you can access is better than the standard of care. And we always want to be improving on the standard of care rather than staying still. And as I've mentioned, cancer care and cancer outcomes are improving over time. And if you look at the trend for survival over time, it is improving steadily year on year. And the reason for that is not because we're giving the same treatments year on year, it's because we're able to access new treatments. But the process of accessing those treatments can take quite a long time. And so sometimes the only way to access a treatment that we think is important is actually through the route of a clinical trial. And I'll talk a little bit more about why it might be that a clinical trial allows you to access treatments that aren't available routinely on the NHS or even available at all across the world. And finally, this probably isn't something that we talk about quite so much. There's lots of other potential benefits from a trial that have nothing to do with having a new treatment. And that's partly because a trial is a whole package and it's a complex intervention. It's designed very carefully over a number of years. And to deliver that trial and to be successful, you need a lot of support. You need bodies, you need people, you need minds who are designing and monitoring. You need support from the research nurses. And actually, that sometimes means you have more tests, more support. And if there are things that aren't going right, you pick things up more quickly than you would under standard conditions. So actually what we sometimes see in clinical trials is that regardless of which treatment you have, people do better than if they were not treated on a clinical trial, treated in the standard way. And that's because there's access to these extra sources of resources and funds that can help people be monitored more carefully and get better support, be more able to make their own choices, which are well informed. So what is a clinical trial? Well, it seems fairly straightforward. It's anything that involves patients, but actually it's not necessarily focused on treatments, pills, medicines, whatever you want to call it. Sometimes a trial is about a procedure, how we deliver our care. For example, in the past, when we treated patients with certain types of blood cancers, such as leukemia, we've had to keep people in hospital in side rooms 24 hours a day, and that can be quite difficult, particularly if it's 4 weeks at a time, which is what a cycle of intensive chemotherapy is like. Now, everyone is different, but sometimes that can be psychologically quite challenging, quite hard. And that's the kind of conventional kind of perception of what happens. But actually, we're now exploring whether we can deliver treatment as an outpatient. So people actually are spending most of the time at home with their loved ones, having much better quality of life, enjoying the food they want and the kind of access to the resources they need. And that in itself can be delivered through a clinical trial. There are many other different, quite innovative approaches of delivering care that are being, again, explored through clinical trials. And when we talk about what types of trials there are, we can break them down, broadly speaking, into about 4 different types, but there are many others as well. So the first and most kind of well recognized is treatment trials, and they very much are comparing different treatments, and often it's the standard treatment. And then the other thing that it's compared to is the standard treatment plus a newer treatment, or the standard treatment compared to a newer treatment. But the second lot that we sometimes talk about is diagnostic trials. So what's happening right now is there's a revolution in medicine. We're finding out more and more about cancers, blood cancer in particular, is at the forefront of this revolution because we now understand a lot more about genetics. So the book that all of our bodies are written in, and how we describe, how our cells describe how they're made. And what can happen with cancer is that there are changes to our genes, and this can lead to the cancer or by a multi-step process. And so if we've got better diagnostic facilities, we can diagnose at a greater level what sort of cancer people have, And there are many different sorts of each type of those leukemias that Noma mentioned. And so if we know specifically which type and subtype you have, we can actually find a better treatment for you. And that's why diagnostic trials are quite exciting and quite interesting. And I would definitely recommend people explore those options if they're available to them. And we'll talk a little bit more about why they might not be available. And then thirdly, the most successful way of treating someone is to prevent them from ever getting the illness or the disease to begin with. And I think we all know that intuitively, but it's not always easy to live a super healthy lifestyle. But there are now trials actively exploring this area, which has been underexplored in the past, looking at what we can do in issues such as our diet, in how we sleep, in exercise. And all of these factors, the air we breathe, can actually help to prevent people getting ill. And there's been a recent large-scale trial which has shown that people who exercise actually live longer, having been diagnosed with bowel cancer as one example, than people who don't. And it's fair to say that if exercise was a pill that we could put in a jar, it would be very valuable indeed. But because it's relatively free and accessible to most of us, sometimes it's perhaps overlooked as the importance. And finally, quality of life. Again, doctors probably in the past have been guilty of overlooking this because we're focused on improving outcomes in terms of treatment, and treatments, of course, have side effects. So we're very much looking at the other aspect, and built into a lot of trials, or separately, is looking at quality of life. Can you get out and about? Can you spend time with your loved ones? How does this treatment make you feel? Can we design treatments that are better, safer, kinder, and don't have all of the side effects that we'll have heard about in the past? So this is all very abstract, but we should probably talk a little bit about why clinical trials matter to you personally. And probably the biggest reason is that research is always ongoing, but it comes out of academia. There's enormous amounts of papers published, but papers don't really mean anything if that's not translated through to the real world, to the bedside. And trials themselves are going on all the time, but these can take many years to set up, design, and then carry out. And during that time, if people aren't aware of their clinical trial options, it means that these options aren't available to them and they miss out. And therefore, their results potentially aren't as good. And in many cases, because of the trial process being so long, we have lots of evidence that these therapies are of benefit. And we know that the process is long, and sometimes that's unavoidable, even though we're trying to speed up access to trials. So we're aware that people can benefit from a trial. And sometimes it's quite frustrating as a doctor when I know that there's a treatment that might benefit my patient, but there isn't a trial available, or that trial's not open in my center, or it's not open in the UK for various reasons. So I always encourage people to find out about trials actively right at the beginning of their patient journey, just to know exactly what options are open to them, and so they can map out their pathway and work out what the best options are for them right at the beginning. So I just thought I'd take you through, since we have a little bit of time and it's a luxury, to go through the process of how a trial works. It's quite very much a multi-step process. There's a lot of thought that goes into it. So the first process is someone somewhere has a bright idea, and that always is the beginning of it all. And often there's a 10 or 20-year process of lots of scientific understanding just to get to that step. And then we actually have to comb through all the papers and all the literature to look at evidence. And all trials should be evidence-based, so there needs to be the solid rationale built upon science before any trial is studied. And once you put those two things together and you have a lot of people working together, you have a study that's designed by experts. But what's really important is that we involve patients, we involve family and the people who are going to actually be experiencing these trials in that process, so that it's designed with patients in mind. And then the other aspect is that these things don't run themselves. They often are a very difficult, complex process. They require a great deal of funding, and that's a very competitive process. And that means that these trials have to go through a very, very stringent process of checking that they make a lot of sense, essentially kicking the tires to make sure everything is likely to work well. And that funding process can be through government, although the sources are limited. It can be through medical charities, and charities like Blood Cancer UK, myeloma UK are tremendously important because there is a gap and there's a lack of funding for these incredibly important trials. And also sources can be the pharmaceutical industry as well. And once we have that funding process, only a few trials actually get through that process. We have an ethics committee review, and that's again really important. So this is a separate group of people who have nothing to do with the trial itself. who are focused and specialized, particularly in the ethics of whether the particular intervention is important, is it relevant, is it going to make key differences, and is it fair? Is it going to make sense from an ethical point of view? And that, again, is something that all trials in the UK have to go through. And often trials have to be rejected or redesigned until they fully fit the remit of the ethics committee review. And as part of the funding process I've mentioned, you need to have a lot of dedicated resources. So this is people, this is research nurses, this is costs of the tests, the special diagnostic and genetic tests that you might have. And that costs an awful lot. And so what comes with a trial is an awful lot of funding that can be very helpful in trying to make sure everything goes as smoothly as possible. And that can sometimes include help with getting to and from appointments and transport and so forth. And all of that goes into just setting up the trial. And then we've got the process of actually running through how the trial works. So we have the treatment. As I mentioned, monitoring is a really important part of it. And as part of that monitoring, we actually see some interesting results. So what we often see from trials is there are unexpected spin-off benefits. The main aim of the trial might have been this, but we see that in a number of people, didn't matter if they got the treatment or not, they did better than previous people. And that might have been because of something the trial did. It might have been because people on a trial tend to think about their health a bit more, to behave more healthily. Perhaps they might eat a healthier diet. Perhaps they might exercise a bit more. Perhaps they might do a little bit of mindfulness and meditation. But for whatever reason, we see this uplift across the board. So a rising tide that lifts everyone's outcomes. So that's the first thing that is perhaps not so talked about in terms of trials. This is seen across the board. And then when we come to analyze the results, we see that regardless of the treatment that people have had, the standard treatment, people seem to do better if they're on a clinical trial compared to people who are treated off a clinical trial. As I mentioned, part of that might be because actually when you start to think about your health, you start to change some behaviors, and that might help you live a healthier lifestyle. As I mentioned, exercise is one big thing, but the diet and nutrition is another really important aspect that we're starting to focus a bit more on. So people who aren't treated perhaps with the newer treatments can still do much better if they're treated on a clinical trial. So that's important to be aware of. Clinical trials do have quite stringent criteria that allow people to enter them. So that can exclude some people. So that's another important aspect, that we're trying to make trials more open and more inclusive. But we can only do that if people actually stand up and say, look, I want to be involved in trials. I want to get access to these newer treatments. And we get everyone involved, including, as I mentioned, the patients, the public, and the community, in shouting about access to trials, because it is unfortunately not something that everyone will be able to access. So finally, if we analyze the results and we look at the results of this new intervention, whatever it is, we might see that there are further outcomes and further improvement from this new treatment. Of course, it's not guaranteed, and what exactly we expect, what the likelihood of that is, that depends on the specific trial. And that's why it's really important that you talk to your doctor and your nurse about what they expect, what their experience is, and what they would recommend if they were in your shoes. As I say, every case is different, and it's really important to know what your options are, because being aware, having more information, I would say, is a benefit. And eventually, if the treatment is successful and everything else aligns, then the treatment may become available to everyone on the NHS. But of course, as we said, that process can take 10 or 20 years. So for an individual person, it's probably not that helpful to be waiting around for that. That will eventually improve things across the board for patients. But for one person on their journey, sometimes you can't wait, and you need to have access to newer treatments at the time. And when we talk about trials, the other important aspect is that there are three main different sorts. And the type that we think of when we hear the word trial is more the sort of phase one. So this is the more experimental trial. So there's some evidence in a laboratory or scientific setting that this treatment might work, but they haven't been tested in lots of patients. And so these trials are more for people who have had all of the standard treatment. And unfortunately, the standard treatment may not have worked, because some people have, unfortunately, diseases that don't respond to standard treatment. Fortunately, that's reducing in many types of blood cancers, but unfortunately, we still do have these cancers that are called poor risk. Or possibly if there's an issue with relapse, and in that setting, if there are no other treatment options remaining, then ethically it's important to explore all the outcomes. And for people who don't have other outcomes, then these trials may be appropriate. The other phases, the more developed phases of trials, are more advanced. These are phase 2 trials. These are trials that have been tested in populations of people, and we've seen evidence of benefit. We know that these treatments work, but what's important now is to work out the precise details. Which population of people do they work in? Is it newly diagnosed patients, or do they work better in patients who relapse? Or is it particular types of patients? And that's what phase 2 trials are about, and they tend to be more advanced, less experimental. And then the final phase, these are very large, often multi-center international trials. These are phase 3 trials. These are treatments that we know work. They've actually been established often to improve outcomes, but now you need to test them in comparison to or added into the gold standard. So can we get even better than the gold standard? Or can we reduce toxicity? And there's lots of examples of these big trials. They're going on all the time. And of course, we see a lot of successes from them. And really, this is how outcomes improve. This is how we move forwards through these trials. But as you can see, it's a multi-step process to get. Why does it matter if a set of people go into a trial and lots of other people don't? Well, firstly, illnesses and treatments behave very differently in different populations. And if we don't study and investigate lots of different aspects of diseases, then we won't find things. And that's really important because at the moment, trials, unfortunately, are overrepresented with certain types of people. These are often people who've got access to lots of information. They might be motivated to explore their options. And unfortunately, that means that populations that are not represented properly in trials won't be able to access the newest treatments. And that's a massive source of inequality. And it's a real worry that across the world, there is this skewing in terms of trial outcomes, and people historically who've gone into trials tend to look the same and be from a very similar background, often a more wealthy background, and able to access more information to make the right treatments. And if we can't reach everyone, then we're going to end up with treatments that only work well for a particular sort of people, the people who've taken part in trials. And often, as I've mentioned, trials will exclude people who aren't, for example, incredibly physically healthy. So we need to advocate for people who look like us, who perhaps aren't all physically healthy, but need to take part in these clinical trials. And as you can see here, the orange circle is kind of the vast majority of people, but actually at the moment, trials are just reaching that blue circle. It's a small minority of people. And in a recent large-scale review, so people look back at 30 or so UK studies, hundreds of thousands of people, what they saw is that there's a significant portion of ethnic minority patients in the population, but compared to the population, the number of ethnic minorities going into these important trials, which are improving outcomes, was significantly lower compared to participants from a white Caucasian background. And if that's the case, then we're going to see poorer outcomes, unfortunately, in these underrepresented patients. And actually, and this is perhaps quite surprising, is that only a third of patients in the UK with blood cancer have the chance to discuss trial opportunities with their medical team. And what we really want to advocate for is always be asking about what your options are and what potential trials are there. As part of that, many charities are trying to make people more aware of this option and also navigate through all this information. So Blood Cancer UK's website has a very helpful link to a bit more information. And they've got lots of initiatives, and so have other cancer charities as well, that are trying to take access to unlock access to more treatments, more trials, and essentially to help more people be aware of their options. So I'm conscious I've talked for a very long time, and I'm going to stop sharing and open things up. Thank you.
That is fantastic. Thank you so much, both of you, Dr. Noma and Dr. Anjum. I think incredibly powerful sessions, and yeah, we've had loads of questions and engagement in the chat while you were both talking. So really grateful for that. Just because I'm just aware of time, I'm just going to move on to the section with Antoinette, and then I think there'll be a time for wider questions later on with everyone. So thank you both very much again. So I'm just going to pull up I did have some questions for you, Antoinette. So as I mentioned at the beginning, we're now going to be joined by Antoinette, who has lived experience of blood cancer for the past 13 years, and obviously shown incredible strength throughout your journey. I'm told that you've bravely taken part in 4 clinical trials, and I know we've just kind of heard about trials, so it would be
Yeah.
very, excellent to sort of hear your experience. So obviously that's an incredible contribution, not only to your own care, but towards the advancement of others, as we've heard the importance of that. So, Antoinette, we're so grateful to have you here today. Thank you so much for agreeing to join and for your courage. As I mentioned, I've just got a few questions for you, if you're happy to kind of to share part of your journey.
Yeah, sure.
Yeah.
So I was diagnosed with multiple myeloma in
Mhm.
February 2012. I had just gone back to work after an extended maternity leave.
Mhm.
And I was just feeling very tired. I mean,
Mhm.
really tired to the point where it started to affect my driving, affect my
Mhm.
work. My job was quite stressful. So I put it down to the job and having a baby, and my daughter was 6 at the time. So I eventually went to the doctors because I thought, something isn't quite right. My doctor, who happened to be an Asian GP who I had
Mhm.
a very good rapport with throughout,
Mhm.
with my pregnancies. And so I told her that I was just feeling tired. She'd done blood tests, and then it came back with that all my levels were completely deranged.
Mhm.
At the time, I wasn't particularly worried. I was just thinking maybe I just need some sort of a boost or something.
Mhm.
So she referred me to my local hospital at the time, to
Mhm.
the hematology department, to run further tests.
Mhm.
Um, I do remember my GP having to have a heated conversation with the hospital because they were refusing to see me at first, putting
Mhm.
down my levels to ethnic neutropenia, which at the time
Yeah.
I had no idea what that was. So anyway,
Yeah.
I went along, and fast forward, they did tests, and then they started to talk about a bone marrow biopsy. And that's when the penny dropped for me. I knew that this was
Right.
serious.
Yeah.
So I had the biopsy, and then it came back with MGUS. So it wasn't
Mhm.
quite myeloma at the
Mhm.
beginning, but I was told at that point to go off, live my life. Many people go through having MGUS,
Mhm.
go through life, and it not turn into myeloma. So
Right.
that's what I did.
Mhm.
But then, unfortunately, 6 months later, I was still feeling the same. They did more blood tests and another bone marrow biopsy,
Mhm.
and it came back with multiple myeloma. So at that point, sorry.
Sorry.
So at that point, I asked for a second opinion because of what the hematologist was saying to me at the hospital, that I
Mhm.
was quite young at 39 to be diagnosed with myeloma. So I got my second opinion at a hospital in central London. I'm not sure if I'm allowed to say. And they done more tests and another bone marrow biopsy, and it came back with definitely myeloma. So I
Okay.
started treatment, and I had an autologous stem cell transplant,
Mhm.
which only put me into remission for 6 months before the myeloma came back. So
Okay.
then they said that I had the T1114 gene mutation, which makes the myeloma tricky to treat, from what I understand.
Mhm.
And so fast forward, um, I'm now on my 10th line of treatment. I'm on my
Okay.
fourth clinical trial. Um, if I could just go back a little to
Mhm.
just at the start of the pandemic.
Yeah.
So I had loads of treatment before the pandemic, different treatments. Um, my only symptom at the time was fatigue. Other than the usual side effects that you get with some chemotherapies, it wasn't, I didn't suffer, too bad.
Mhm.
I think
Mhm.
I managed quite well. But then I was washing my hair over the bath one day. I stood up, felt a sharp pain in my back, didn't
Mm.
think nothing of it, went into my bedroom to get my hair dryer. Then I couldn't bend. Luckily, my husband was home.
Mhm.
So he came upstairs, helped me into bed, called my clinical nurse specialist. From what my husband was saying to her, she knew that obviously something wasn't right. He drove me down to the hospital in central London. By the time we got there, I couldn't get out of the car. Fast forward, I had a scan, and the myeloma had spread to my spine. I gained 13 spinal fractures.
Wow.
I lost 3 inches in height. I couldn't walk for a while. I had to end up having kyphoplasty surgery. And I'm now left with kyphotic deformity as a result of it being the pandemic, not having surgery straight away, putting a off-the-shelf brace, being given fentanyl. I mean, and even at that point, I had to advocate for myself to get surgery
Yeah.
because the services were stretched. But that's another,
Yeah.
subject. But with clinical trials, I will say, to anyone considering a clinical trial, definitely, speak to your oncologist and definitely consider and go ahead, because the clinical trial that I was on just before this one put me into remission for 18 months. Now, I was diagnosed in February 2012. None of the standard treatment options that I had
Yeah.
never got my myeloma, my paraproteins down to probably about 5 was the lowest. Even at the transplant, the lowest it got down to was about 9. So if it wasn't for the previous clinical trial that I was on, I wouldn't have had that 18 months of remission. Unfortunately, I relapsed again in July of this year, and I'm currently on number 10, clinical trial number 10,
Okay.
and on my second cycle. But yeah, it's been a journey, but
Yeah.
I'm just grateful for clinical trials.
Yeah.
I
Yeah.
actually believe that I probably wouldn't be here talking to you now.
Thank you so much for sharing that. I mean, I kind of knew of the courage before, but actually hearing it from you and hearing your experience has been, yeah, it's an honor to hear. So thank you so much for sharing that. And I think you highlighted so many important things. I think one of the things is, the importance of being able to advocate for yourself, but also having other people, other professionals advocate for you. You mentioned that your doctor kind of pushed when there was a bit of pushback from doing those tests, and that ended up being contributing to the diagnosis in the first place. So yeah, thank you so much for sharing that. And I think we maybe have time just for one more question for you, because you've kind of gone through a lot of the questions anyway. So I just wondered what if you know of any myths or worries that people have about clinical trials, and how you would address them, those kind of fears that people tend to have about clinical trials and things of that nature.
Well, yes. So when I mentioned to my family, in particular, like the older generations of my family, straight away it was, no, you do not want to go in a clinical trial. They're going to use you as a guinea pig. Look what they done to, all those black men in the, is it Tuskegee?
Yeah.
They're going to do the same thing to you. Why are they testing on you?
Mm.
So, I did have those voices in the background, but, for me, I just thought, well, what are my other options?
Right.
I
Yeah.
want to be alive. I want to see my 2 children grow up and meet milestones. The doctor's already said there's no more standard treatment options for you. However, but this is a good trial, and you just have to trust your doctor. And I think for a lot of doctors as well, there needs to be some sort of cultural competence in
Yeah.
how you speak to someone from an ethnic minority,
Mm-hmm.
you know, to try and alleviate those fears. But you know, anyone that says to me now, I mean, even some of my younger members of family, you know, that are dead against vaccinations and stuff like that.
Mm-hmm.
You know, when I tell them that I've lost count the amount of COVID vaccinations I've had,
Yeah,
you know, but then
yeah,
I have to break it down to them about the whole issue of me being immunocompromised.
absolutely. Yeah.
You know, so I think a lot of it is education and getting through to people to understand
Mm-hmm.
that there are reasons behind these things. And it is, you know, as I said before, if it wasn't for clinical trials, I wouldn't be here now.
Mm-hmm.
You know, so, you know, I'm currently on number 10 now, and I'm praying that this does what it needs to do, hopefully put my
Yes.
myeloma to sleep, because as you know,
Yeah.
there's no cure at the
Mm-hmm.
moment for myeloma.
Yes. Yeah.
But you know, if you know, I don't even want to say it, but if I do
Yes.
need to go into another clinical trial,
Mm.
I will jump at the chance.
Yeah.
You know, and I've even been on trials where I've been first in human testing, which
Mm-hmm.
was
Incredible.
scary,
Yeah.
you know, but I have no regrets.
Yeah. Fantastic. Antoinette, honestly, thank you so, so much for sharing, with such honesty and openness, and your courage. And I know that your journey, your story has definitely been, encouraging to everyone who's watching and who will watch in the future. It all obviously links together in terms of what Dr. Noma and Dr. Anjum has spoken about in terms of the clinical trials, and I think you're quite literally living proof of the importance of that. So thank you so, so,
You're
so very
welcome.
much.
Thank you for having me.
And yeah, we all wish you the very, very best with everything going forward, and really, really appreciate you. So
Thank
thank you
you.
so much.
Thank
Thank
you for
you.
having me.
Thank you. And then we're now honored to maybe hear a final word from Cecil, who's also has lived experience. I don't know if Cecil is still.
Yeah, I'm here. Yeah.
Yeah. So yeah, thank you so much for joining as well. I think again we're really honored to have two people with lived experience, and thank you for joining us, and also being willing to share your voice today. So Cecil, I just wondered, as we kind of come to the end of our lived experience segment, if you had any final messages or encouragements that you'd like to share with others.
Yeah, I know the time is short, so I'll keep it quite
Mhm.
brief.
Yeah.
My background is I have a blood cancer called myelofibrosis,
Hmm.
and the long and short of that is it's causing chronic anemia. So it's
Hmm.
really knocking my red blood cells down. Um,
Okay.
and we're trying medication to try and bring that back up. At the moment, we're not having much response. The actual only cure for it is a stem cell transplant, which is basically
Hmm.
where you replace my, referring to the doctor's description, my blood cell production machine with somebody
Hmm.
else's. And it's very hard to find a match within the Black and Asian community, typically
Hmm.
because in our communities we don't donate, we don't join the register as much because there's
Hmm.
myths, there's fears, there's the lack of understanding of what's involved in that. So for someone like myself, it's like there's a cure out there, but it's hard to find a matched donor to invoke the cure, which eventually I'm most likely to need
Hmm.
um, if the condition keeps progressing. So I'd just like to say to people, really consider stem cell donation.
Yeah.
It, it's to keep it very brief. It's harvested from your bloodstream, so they don't have to
Mm.
drill into your bone or anything like that to take stem cells out of your bone marrow to give to a donor. It's
Yeah.
harvested from your bloodstream using the process. So it's a bit like being a blood donor when you're going through it. It's different, but it's taken from your bloodstream, and I just really want to get that across that it's not
Hmm.
as scary as people think. I mean, I've started a little bit of a campaign for myself, and
Okay.
even when I drop my initial campaign into groups, everybody
Hmm.
goes quiet. Nobody wants to respond because you just know that they just don't want to do it. There's
Yeah.
that much misunderstanding.
Hmm.
So I need to try and do some education within those groups myself. Last thing I would say is dkms.org.uk is where you can go to be a stem cell donor to register. Between the age of 17 and 51, you can join the DKMS register. So that's Delta Mike Kilo Sierra dkms.org.uk.
That is amazing, Cecil. Thank you so much. I think that's really, really important. You know, obviously, again, kind of talking about advocating for yourself, and some people put in the chat previously about the importance of education and people knowing what to expect and things like that. I think it seems like, you know, that work that you're doing is really important. If you can, I'm sure we can probably share that at some point. But if we can maybe put that in the chat so that the website that you mentioned, I think that would be really, really helpful. So yeah, again, thank you also for your courage and your openness in sharing and your ongoing advocacy work. And yeah, we wish you all the very best and I really appreciate you for joining. So thank you so much.
You're welcome. Thank you thank you for giving me the time.
Thank you.
Just
Great.
I noticed somebody put in the chat there is a number of registers. So somebody put in the chat there about Anthony
Nolan,
Nolan.
yes.
So there is a number of registers, and I'm trying to remember. I think Anthony Nolan is more geared towards younger people, I think. But the only reason why I mentioned DKMS was because it's got the widest age range of who they take on to register. But there is Anthony Nolan as well.
Yes.
Thank you.
Great. Awesome. Thank you so much. I'm just aware of time, but if everyone is happy to, because obviously this is such a huge and an important topic, so if everyone's happy to stay on a little bit longer, we can go through some of the questions that have been asked. So two things, I don't know if this come up for everyone, but a poll has come up. So if you could please engage with the poll, it is really helpful for for future sessions so that we can continue to produce sessions and work like this. So again, just continuing to thank you, I think is really important to say thank you. So if it seems like I'm saying thank you too much, I think that's why, because I think it's important. People are sharing their stories, people are sharing their knowledge, and we are very, very grateful. So we're just gonna go through the questions and answers sessions, if that's okay. So if we could get maybe Dr. Anjum and Dr. Noma back. We've just got a few questions which I will read out. Please feel free to continue to put your questions. It'll be really helpful. So first question was asked, I think it's Agatha. Agatha was asking why other people start radiotherapy. Why chemotherapy doesn't work very well for other people. And someone started chemotherapy on his kidney and was able to finish 3 cycles and was clear, and later told the cancer had gone through the lungs and head. Why does this happen?
I can take that if you like. Yeah, so
Sure,
I think,
thank you.
as you'll know, every case is individual. Everyone's cancer, unfortunately, is different. And it's all about finding out what's the specific situation that you're in, because some people's cancers will be, if it's a solid cancer stage 1, so it'll be localized to one area, and so the outcomes are much better. Other cancers will be more advanced, and that's really important to know. But the other aspect is that even if you have bowel cancer, that's completely different. For example, someone with blood cancer is everywhere. So in a sense, if it's in one area, that isn't relevant. That's relevant to a solid cancer. But blood cancer is everywhere, but that doesn't mean you can't cure it. Actually, it means that the treatment can go everywhere. So it's really important to know what is it about your particular cancer, and that all comes down to, your doctor, your nurse talking to you, explaining what the situation is, and then by all means feel empowered to go online, go to reputable websites, Blood Cancer UK, Macmillan. They're the ones that are going to give you the right information about how successful your treatment is likely to be, what the figures are. Because unfortunately, the treatments won't work for everyone. The other best treatments you can access, they should be offered to you, but unfortunately, they're not 100%. So knowing what your options are, knowing what the outcomes are, helps to avoid, fortunately, situations where people are devastated later down the line, find out these situations they're in.
Yeah, no, yeah, absolutely. Okay, fantastic. And Agatha had another question, which I think is been answered already, kind of throughout the talks. She's just asking, do you educate or provide details of the clinical trial so that people participating, and to know what he or she is about to be involved with? Yeah,
Yeah, 100%. I mean, that's the
yeah,
most important part of a clinical trial, that you can't just
absolutely.
enter people into it. It's all about your own individual personal decision. And you need the time, space, you need the right information to make that decision. So there's actually a whole legal framework around this, that you're given
Mhm.
lots of information, and some people like lots of written information, some people like to talk it through, whatever you need. But that's really important. And you need the time as well. You can't just
Yes.
be forced into a decision. You need to
Hmm.
make that. If you've got family and friends to help you support, that's great. If your clinical nurse is able to support, that's the other main option. And of course, charities and things. But it's all about your own individual decision. And the important thing is that, you need to be careful that there are benefits, there are potential risks as well, and there are potential side effects. That doesn't mean everyone gets the side effect. It might be 1 in 100, but good to know
Hmm.
about these things, really important. And then actually, if you go on a trial, it's not agreeing with you, of course, it's 100% your decision to come off the
Hmm.
trial. It's not like you're bound in stone. But yeah, this is all about informed consent.
Yeah, yeah. And I think that point you just made about, not being bound, because I think sometimes people, I don't know if people have this idea that once you start, you're kind of stuck in and you have to continue.
Mm.
But I think, as always, education is important, and people knowing that they continue to have options, whether or not they decide to go on the trial or not. It's not
Yeah.
set in stone, it seems like, which is I think is important for people to know as well. Yeah. Okay. And then there was another question, which is about genetic testing. So, Agatha again was saying, do you consider that some people from ethnic backgrounds, like Black and Asian, are not really Black and Asian in terms of when you go down to their roots? So down to the roots, some other other ethnic backgrounds that I don't know of. So, would you suggest DNA testing before trials? Is that kind of, is that relevant? Is that important when it comes to these
Mm.
trials?
Sure. So the testing that we do is very extensive, and
Mm.
there's a whole lot of testing that happens on the NHS. And then within trials, there's extra testing as well to see if a particular treatment is suitable for a particular person. So then often trials aren't focused on a particular race or ethnicity, but what happens is that unfortunately people of ethnic minorities are underrepresented. And there's a big push now to try and ensure that people have access to these options. So it doesn't necessarily mean that you'll be excluded if you're a particular race or heritage or
Mm.
whatever. But we do a lot of detailed genetic testing. When we say genetic testing, that's testing mainly on the cancer. This isn't
Okay.
your
Yeah.
own blood cells and your
Hmm.
heritage. This is more about the cancer, because if the cancer's got to change, then we may be able to target that change with a better, safer kind of treatment. And these are coming along all the time. So it's important to know if you've got that.
Amazing. Perfect. And then I think the rest were just sort of more so comments. So uh, again, I mentioned that sometimes people don't want to participate because they need to understand, and have knowledge of the trials, which is kind of what we're saying. So yeah, very important in that regard. And Antoinette actually mentioned about no match being able to be found. So more ethnic minorities are needed to save more lives, which is kind of on what Cecil was speaking about. So yeah, very important. Um, any other questions before we kind of go to final words from Dr. Noma and Dr. Anjum? I can't see any more questions, but thank you everyone. Yeah, I think they've all been asked. Oh no, sorry, I took my second. Sorry, I just saw the questions from YouTube. There's one question from YouTube, which is that, is it true that untreated HPV in the cervix, if ignored, can spread to the lymph nodes and lead to cancers in the blood?
No, I don't know if you want to take that, or I can take that up to you.
No, I'm going to let you answer this one.
Yeah.
Thanks.
Yeah.
So HPV, was it? Human
HPV,
papillomavirus.
yeah, so
Yeah. So
yeah.
as far as I'm aware, that can, and it's present in a lot of people, but in a small minority of cases, that can unfortunately lead on to cancer of the cervix. And so that's why this vaccine is being offered to young girls, because that can completely prevent this issue, and that's a fantastic advance, this vaccine. I'm not aware there's any evidence that that can cause other cancers, like cancers of the blood or the liver. But of course, if people have advanced cervical cancer, that cancer can spread to the liver. So that's a metastatic cancer, but it was from the cervix originally. But it's all about, as I mentioned, the prevention. The best way to treat any cancer is to prevent it through access to these newer treatments or vaccinations and healthy lifestyle.
Fantastic. Thank you both so much. Thank you to everyone who's contributed today. We've kind of learned such a huge amount in such a short space of time. So thank you everyone, Dr. Noma, Dr. Anjum, Antoinette, Cecil, and everyone for your questions. As I mentioned briefly at the beginning, there is a peer-to-peer support group with a collaboration between Blood Cancer UK and Khan, and I believe there'll be more information about that. But it's again, it's something that's being piloted, and it's kind of again further further support and a safe space to connect with other people who are living with blood cancers, as well as their relatives and carers. So if you or anyone else who feels like they would benefit from it, please do get in touch, and so that you can participate in that, because it's really important. So thank you again, everyone. I'm going to keep saying thank you. So from Dr. Noma, we learn about blood cancers, starting in terms of the genetic stage and the bones, and the different types of cancers, and kindly remind us about the symptoms, such as tiredness, bruising, and diagnosis involving blood tests and bone marrow biopsies, and then treatment is highly personalized. We spoke about the nurses, and they do sound like angels. They do sound a very important part of the journey. And then obviously Dr. Anjum focused on the clinical trials and why they are so crucial, and trials not being about being guinea pigs. I think Antoinette mentioned that as well, not being about guinea pigs, but sometimes they are one of the ways, one of the only ways for some people to access the newest and sometimes most effective treatment, and the people in trials are monitored really closely and overall do better. So really important that we as a community are engaging in these, so that we can have better outcomes for ourselves as well. Very special thank you, of course, to Antoinette and Cecil again for sharing your powerful lived experiences. Honestly, your openness, your courage, your honesty and advocacy, I know has changed the lives of people during this chat, but also I know wider people as well. So as I mentioned before, this is a pilot partnership collaboration with Blood Cancers UK. So your feedback is really helpful. I know that the poll did pop up. I don't know if it's still there, but I believe there is a survey link in the chat that you can kind of access. So please do let us know your feedback. So yeah, thank you everyone again for contributing, for joining, and then I will hand over now. I think it's to Isaac.
Thank you very much, Dr. Jessica, for sharing with us. And I must say today has been a very insightful and amazing session. And I'm sure we all learned so much from today's session. And on that, we want to say a really big thank you to Dr. Noma and to Dr. Anjum for taking our time to share with us from their sea of knowledge. And we also say a very big thank you to Antoinette and to Cecil for sharing too their lived experiences, and a lot of misconceptions were addressed, and so we're really thankful to that. Thank you very much again, Dr. Anjum. It's nice to have someone from a different ethnicity with us on the Health Hour. I'm going to be sharing my screen now.
Thanks so much. Pleasure to be here. Really enjoyed it.
Thank you so much.
Please let me know if you can see my screen. Okay.
Yeah, we can, yeah.
All right. So thank you very much once more, and do join us next week as we'll be having another professional share with us on chronic kidney disease. The time is 11 to 12 a.m., 11 a.m. to 12 p.m. as usual. And you can come learn a lot. You know, if you have questions, you ask your questions. Please do well to share with your friends, share with your family. You'll be helping someone if you do that. And you can scan the barcode to register, or you can email info@can.org.uk. And also on Tuesday, the 2nd of December, there'll be a peer support forum. And, you know, if you're of Black ethnicity or Pakistani, do well to come learn, share, and empower others on blood cancer. You can also scan the barcode to register, and it's going to be online on the 2nd of December at 6 p.m. Join us on our Joyful Carol service, the Caribbean African Carol service. It's coming up on Tuesday, the 9th of December at the Manchester Cathedral, and the time is 7 p.m. and admission is free. Please do well to register. There'll be lots of activities, and you can also email events@can.org.uk for more information. Okay, so CAN has partnered with SGN to bring essential support to Black and African houses across Croydon, Lambeth, Lemusham. So we'll be offering free carbon monoxide and alarms and safety energy efficient guidance to reduce energy efficiency guidance to reduce bills, income maximization support, and priority services register assistance. So if you'd like to have more information on this, you can email saferhomes@can.org.uk or reach out to the phone number on the screen. We also offer Black-led counseling services, and if you're a qualified registered counselor or you're looking for support, you can also do well to reach out if you have any questions for us, for our counselors, for yourself, for someone you know. Do well to use the referral form. You can scan the barcode or email counseling@can.org.uk. And if you need support with any of the followings, domestic violence and sexual abuse services, you know, advocacy service, home office sessions, family and advocacy sessions, and legal drop-in, you can also reach out. There's a helpline below. You can reach out to number or email advocacy@can.org.uk. Or also there'll be free health checks and advice in Lewisham. So do well to visit the Safe Steps team at Lewisham Community Center on the 2nd of December. There'll be free health checks, expert advice, and also refreshments. Just to emphasize, the venue is the Lewisham Community Center, and it's taking place on the 2nd of December. So you can also scan the barcode to take advantage of this opportunity. And to that, we say a very big thank you to everyone for joining us on this session of the Health Hour. And we do hope to see you next week. Thank you, and do have a wonderful weekend.
That's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.